think the order was so that Ian can have a go at me and then leave. Okay, this topic was when not to operate on, and keep in mind, I will try and keep it general, but we do have an orthopaedic slant, keeping in mind that some of the problem is that we do work off a different model of care in orthopaedics. We rarely deal with cancer. We deal with pain and deformity, and fractures of pain and deformity. So we tend to look at this slightly different. So my declaration of interest, I got a free polo shirt once, and my other declaration is that when I was a junior registrar, there used to be, when we had our clinical meetings, there was an old person in the back corner who at the end of any discussion would just pipe up and say, don't operate on that, that won't work. I am now that old bugger in my department. The old term, the operation was a success, but unfortunately the patient died. Well, that's not good enough, that's quite obvious. So what is the next one after that? The operation was a success, but the patient feels no better. Sorry, that wasn't me. I don't think that's good enough either. So how do we assess these things? There's lots of different ways of what worries the surgeon and what worries the family. Obviously death worries the surgeon, an infection, DVT, recurrence of the disease, more pain, and repeating surgery too often. What worries the patient and the family? Again, death. And as it is a QASM, I suppose we need to mention that a little bit. Further disability, including cognitive. And I think that's one of the things that gets ignored a fair bit these days. How much damage do we do to the patient mentally if we push on too hard? It's not the latest innovation. I want to be 18 again, and I get that. You know, the patients come back and say, oh, I'm not completely convinced by this joint, and it says, why? What do you want to do? I want to go to base camp. Base camp of 5,000 metres after a 72-year-old after a hip replacement. I think I had a discussion about that's not the world's brightest idea. So should we be looking at something different like patient-centred outcomes? Outcomes that might matter to the family and the patient, they probably need to be distinguished. And, you know, mortality obviously is one of the patient-centred outcomes. The patient might not know much about it, the family do. And what we're going to find is increasingly there's going to be healthcare purchasing decisions by third parties. They're going to be looking at this as well. The federal government is looking at costs of prostheses. I've got a pamphlet from one of the private health funds recently going through, and they were tracking what patients and what surgeons, they didn't name them, how many they did and what the costs were and what out-of-pockets. Did they go to rehab? Did they not? It was quite fascinating to look at. So we've got to be careful. There's going to be other things that are going to go on to discuss with this. An example we could bring up related to this is fractured neck of femurs at the moment. There is a lot of money and a lot of meetings and thoughts about research outcomes of what's going into these. There's lots of different models of care that kind of been developed that really are very similar, but is it actually changing the outcomes on these patients? Not sure yet, and I don't know if we're really tracking them well enough to say is the morbidity or the mortality of these people at 2 years any better than it was when 30 years ago, and you can almost argue that it's not much. So are we then paying attention to what the families and the patients want out of this? We're looking at all these, mortality figures, but what do the patients and the families want? An example of this, how do we find some ideas of how to look at this? Is there anything out there? And it has been mentioned about the American College of Surgeons, which has a risk calculator that you can discuss with the family or the patient. That's a National Surgical Quality Improvement Program. But it's only actually for the outcome in the first month. It's 1 month. Don't you hope the patient's going to at least have a 5-year survival rate? It may be used to encourage the American surgeons when informing the patients about the risks. So I decided to have a look at one of the last knee replacements I did and compare that. I originally thought about I might put a Hartmann's in there. I looked at the complication rate and I thought I'd better tone it down and went for the laparoscopic right hemicolectomy. So I had an 82-year-old lady, ASA3, a few other things, and it clicked up, serious complications, 5.3%. This isn't a knee replacement, this is for pain. This is not a life-threatening condition. Is that acceptable? Well, I operated on her and she did all right, so I considered it was. But there are a few things you've got to look at that and wonder. Discharge to rehab, 55%. Yeah, she went to rehab, she went home 2 weeks later and she's doing fine. But to be careful of how you interpret that nursing or rehab facility as well. That's a bit distorted. If we looked at the right laparoscopic right hemicolectomy, complication rate 11.5% double. Is that acceptable? It's cancer? Yes. It's a life-saving procedure? Yes. So yes, it probably is if you sit down and discuss with the patient. If it was my knee replacement, I'd be starting to have my doubts, if it's worth that. There was a process where they checked on this of what they thought, would it change the surgeons at all? So they did a study, it was almost basically a control and a various site at one of their meetings where they looked at mesenteric ischemia, gastrointestinal bleed, small bowel obstruction, appendicitis, so things that may or may not need an operation. And you can argue either way or not with where you go. So they did a control group and they did a supplemented group where they had the idea of the informed risks using this calculator. And in fact, although the supplemented group seemed to be better informed of the risks, didn't change the decisions of the number of people who operated. So is that useful or not? Probably medico-legally, but on the discussion, I would have my doubts. Is there anything else local that might be a bit more use? And there's a process at the moment that's being developed called Crystal. It's in the University of New South Wales. It stands for Criteria of Screening and Triage of Appropriate Alternative Care. This is much more general. It's not about surgery, it's about everybody that comes through that may or may not need discussion and predict or to start a discussion with family about how far do you go. The idea was to reduce the uncertainty about patients that might die within 3 months. And we have these patients that come through with neck ephemas that you wonder about. It was supposed to be developed as an unambiguous list, reducing uncertainty. It includes a whole range of things that they went through a process looking at all the papers that are around. I'm not going to go through that, you can have a look yourself, but it is still only in the development. Okay, they've done a retrospective validation, which they're now trying to complete the data retrieval and the analysis. They're doing a prospective validation where it's completed the 2,100 cases to look at what they should and shouldn't be doing. And the hope is that they can actually make it simpler than the 18 things that they had. It'll be interesting to see if that will help us make any more decisions of the patient that comes in from the nursing home that needs something done. What do the patients and the surgeons, what do the surgeons want, what do the families want and patients want? That discussion, well, probably if someone's going to die within 3 months, they're probably not too much involved with that discussion. So for someone that's not in that 3 months, what else have we got? The possibility of post-op morbidity mortality, or can we discuss things like disability-free survival? Is that a better way to talk about it? And there's some evidence out there, and this article came out from the anaesthetist. It started more as a validation tool, but when I read this, I actually found a few things in there that scared me even more. It's just one of the things out there, there's various others. So they were trying to validate this against the other things that existed previously. They had 510 operations broadly looked at, based out of non-ASH, and included orthopaedics, some emergencies, a whole sort of range to see if they could see if it was validated. And that's the process there, but I picked a few bits out of this just for my interest. They talk about disability afterwards. And new disability was the one that fascinated me. That someone who'd had these procedures at 3 months, 18% of them had a new disability, and most of that was unrelated to the original index surgery. 6 months it had started to get better, so they've had other problems. So are we operating on people that are starting to fall apart already? Okay, other things that came out, obviously ASA 1 and 2s did better. 3 and 4s, that should be 3, I'm sorry, delayed recovery. They all seemed to plateau at 6 months, so you got your outcomes at 6 months. And they did actually separate knee and hip arthroplasty. So Ian talked about the Oxford scores and how well it went. 53% disability-free survival at 6 months. So 1 in 2 of these people are having a problem with something else or new. That's not good. That's not what the patient came to you to want. 1 in 2, and I'm saying, okay, maybe we need to look at this a little bit more. The new disability after the surgery was more likely in someone who had 1 or 2 more post-operative complications and a longer hospital stay. And that's probably a reflection of the patient. So are you deciding on these people correctly? Not all post-operative disability can be directly attributed to index surgery. But where does this put us all? You know, what type of patient and where are we looking at? So trying to summarise this a bit more, do we need to look at other conditions a little bit deeply of how we look at them and how we manage them? And my thoughts on that was, I personally believe that in fractured neck of femurs, it's not a disease in itself. It's in the elderly, it's a symptom of signs of the patient overall, of where they're headed and what's going on. And we're trying where we are to change our model a little bit further than a lot of other places have. And instead of, it is shared care, but we're working primarily on these patients being admitted under the orthogeriatricians. And we're kind of the secondary consult process on that to get these patients maximised so we can operate on them properly, and maybe even start the discussion, which we're looking at, of identifying the patients there we won't operate on. Because there are patients that, even though the family, from the moment these people get in put in the ambulance, you know, the paramedics will be going, oh yes, you're broken hip and feet, they'll fix it and you'll be right. Well, that's not exactly true. So there are ones that we really probably shouldn't be operating on that we are. They should be inducing a palliative care process beforehand. And we're hopeful that where we're looking at it, we're getting mature enough to start having those discussions. And maybe we do need a bit more of these tools to help identify the ones. Should we be extrapolating this a bit further? Well, I think we should be. And I would like to try and I'm trying to get a situation where we actually have some of our joint replacement patients are also assessed by the orthogeriatricians about their cognitive status. They're better at it than we are. They're better at it than the anaesthetists about discussing with the family, and then that these patients will struggle afterwards. They'll have a delirium. They may even not get out. And perhaps they are not the ideal candidate for an operation for a knee or a hip replacement. Okay, so in the end, when do we don't operate? Well, obviously, mortality is a poor outcome. We don't want them to die on us. Should we be looking at disability-free survival outcomes of whatever format we are? And I think we shouldn't. We should be doing that more than we do. Is a WOTUS along the lines or something similar have relevance? I think you've got to decide that on your own, or what you think is better, and stick to it and look at it properly. And I'm going to try and see how practical some of this idea is to institute in our service. Thank you. Any questions? Or are you all too dumbfounded? God.
What happens to, this is for the non-orthopaedic surgeons in the room, what happens to a fractured knob that doesn't have the fracture fixed?
There's some information out there. Most of it's based around nursing home patients with intercapsular, so what we call subcapital fractured neck of femurs if they're undisplaced. There was an article floating around from the Swiss that one unit operated on none of them, but they suddenly discovered that they had a very high complication rate where it did fall off. That's the question we're trying to work out now. There are certainly people you will need to do. They are better operated on, there's best pain, but sometimes we're wondering at the moment in the patient, we're not sure, are we better giving them proper pain relief with continuous local anaesthetic catheter to block that pain while we find out if they're actually going to survive? And I almost consider that a trial of life. It sounds odd, but I think there's patients that we shouldn't be.
So this is separate from sitting in traction for 6 weeks, though?
Yeah, well, the traction pretty much is gone. You barely find traction beds, which drives me nuts. anywhere, but putting someone in traction is a very rare process now for more than a couple of days. If ever. Kids.
What about the KPIs should fix it within 48 hours?
It's not actually 48 hours. No, it's even more of a problem. It's 2 days. Now, what is 2 days and this is the third-party money provider, which is Queensland Health. If you have someone that comes in with a fractured neck of femur at 11:55 p.m, at 12:01, they're day one. So you've got 2 days. That's 2 days. So you don't have 48 hours to get them done. So pretty much you're up the creek already, trying to get them right. So they're pretty much day 2. So it's almost 36 hours. But patients are sick when they come in, and there are some caveats that you don't, if they can be delayed, if they've got other complications and things like that. But, you know, I'm trying to work on the principle and trying to think a bit broader again as the old bugger in the corner. Don't operate on that. That's not going to work for the patient. And there are people that I think we shouldn't be operating on that get pushed through the system that cause all sorts of problems. And as another bizarre thing, creates an awful lot of work. We were discussing a patient recently that died in ICU after having their neck of femur fractured. They were fixed. 5 different groups looked at it. 5 have looked at that patient, yes. Our own department mortality and morbidity meeting. The coroner had a look at it. The QASM had a look at it. Our separate mortality and morbidity fractured neck of femur meeting had a look at it, and also the anaesthetists now look at it. So they're all presented in this sort of process. Are we, you know, I think we're going a little bit too far in how we're looking at this stuff. You know, it's all supposedly to help the patient, but we're not identifying the scenario of what we should be looking at. Is, you know, who are we going to help most? It's not an easy discussion at times with family where this is not a great idea, particularly when they've all been fired up. Mum, you know, grandma's going to get an operation and she's going to be fine. The standard outcome for a fractured neck of femur is in an elderly person generally, it's pretty much almost as bad as the neurosurgical side of things. 1/3 at 2 years, 1/3 are dead, 1/3 are in a nursing home, and 1/3 might be back to their pre-morbid state. And has that changed? I don't think we've got anything that changes that at the moment. And that's what we've got to look at a bit. A lot of money's gone into this, and, you know, we spend time and we go to different meetings, and it's, you know, we need to re-look at our models of how we're looking at it. And the nice bit I thought was that the bit with Trevor Fayers earlier today, he said 2 pillars not working well. I don't think 2 pillars works musculoskeletally at all. It's, you know, I have much more to do with my orthogeriatricians, my anaesthetists, and I say hello to Michael in the corridor maybe once a week. So we've got to re-look at some of this stuff a bit better.
All right, more questions and answers from Russell.
Well, it was always going to be the question, you know. You've got to work it out. So.
We've spoken about the interface between